بسم الله الرحمن الرحيم. هنتكلم النهارده عن الفور ارم ريست اند هاند انجريز. الاي ال اوز بتاع محاضرتنا عن الفور ارم فراكشرز، الابلايد اناتومي والفراكشر فاريانت والالترناتيف تريتمنت. الديستال ريديال فراكشر عايزين نعرف فيها الراديولوجي انتربريتيشن اوف ذا نورمال فراكشرز اوف ذا نورمال اند ذا فراكشر اوف ذا distal radius, formulation of plan for treatment of the distal radial fractures and analysis of common complications. بالنسبه للسكافويد فراكشرز كواحد من الموست كومن فراكشرز اوف ذا كاربال بونز، هنتكلم عن الايدنتيفاي الاناتومي، الميكانيزم اوف فراكشرز، الكومبليكيشن والالترناتيف تريتمنت. زي ما احنا عارفين الفور ارم بونز بتتكون من الراديوس والالنا، وان الراديوس والالنا في انترولاترال بوند بالنسبه للراديوس، وان الاناتوم بتاعنا في راديوس والالنا دول ارتكيوليتنج بروكسيمال وذ ايلو جوينت اند ديستال وذ ريست جوينت، زائد ان في بروكسيمال راديو النر جوينت وديستال راديو النر جوينت بتتم عليهم الروتاتوري موفمنت اللي هم سبينيشن اند برونيشن. الفور arm fractures, to obtain functional results or satisfactory functional results after the fractures, we need to maintain the length of each bone, and the axial and the rotational alignment must be achieved, and the radial bowing must be maintained after the reductions. Multiple classification for the forearm fractures, including level of fractures, pattern of the fracture, degree of the displacement, and the presence or absence of comminution or segmental bone loss, open or closed fracture, disruption of the proximal or distal radial ulnar joints. Symptoms and signs of the forearm fractures include pain, deformity, loss of the function of the forearm and hand, tenderness at the level of the fracture, swelling, and crepitation. As regards symptoms, signs include also neurovascular assessment, especially for the anterior and posterior interosseous nerves, tendon evaluations, skin condition, and compartment syndrome. Radiological evaluations include X-ray of the whole of the forearm extending from the elbow to the wrist, so from the joints above to the joint below. As regards the treatment of the forearm fractures, we accept only anatomical reductions for any patients more than 12 years old. Open reduction and internal fixation is recommended in adults, and open reduction or internal fixations with blade versus flexible rod in children. As regards the Galeazzi fracture, this is fracture of the distal third of the radius with subluxation or dislocation of the distal radial ulnar joints, and best treated operatively with open reduction and internal fixations, with fixation with dynamic compression plate, small dynamic compression plate. This is algorithm for management of the Galeazzi fracture, which is include open reduction and the internal fixations of the shaft of the radius, and then intraoperative assessment of the distal radial ulnar joint. If the distal radial ulnar joint reduced and stable, so we allow protective splint and early motions. If it is reduced but unstable, so search for the styloid fractures of the ulna. If no styloid fracture fragments, so K-wires bending fixations fix the ulna to the radius and immobilize in supination for about 4 to 6 weeks. If there is large ulnar styloid fractures, we do open reduction and internal fixation of these styloid fragments and then immobilize again in supinations for about 4 to 6 weeks. As regard irreducible distal radial ulnar joint, this need open reduction of the distal radial ulnar joint and look for any soft tissue interpositions which prevent the reduction. This is an X-ray showing Galeazzi fracture dislocations and showing the method of the internal fixations, open reduction and the internal fixation of the shaft radius, and screw for the fragments of the styloid ulna. The other X-ray showing the Galeazzi fracture dislocation also, and fixation with open reduction, internal fixation with a small DCB for the radius and K-wire connecting the radius and the ulna together. The other variant of the single bone fractures forearm including Monteggia lesion, and this is fracture of the proximal ulna with the dislocation of the radial head. And this needs close treatment for most of the pediatric fractures, but in the adults it's need need open reduction and internal fixation or stable fixation with the plate and screws for the fracture of the shaft of the ulna, and intraoperative assessment of the proximal radial ulnar joint. This is plain X-ray showing Monteggia fracture dislocations before the reductions and after the reductions. We can see the head radius dislocated in the first one from the proximal radial ulnar joint, and after the reduction the head of the radius reduced in its normal position. As regards the distal radial fracture, this fracture is metaphyseal fractures. This fracture represents fracture of the distal end of the radius, and there is normal radiological assessment of the distal radius showing that there is palmar tilt, means that the distal articular surface of the radius palmary tilted, for about 11 degrees, and there is radial inclination about 22 degrees, and the ulnar variance from -1 to +1 millimeters. This X-ray, this is normal X-ray of the distal radius, showing what we mean by palmar tilt in the lateral view, radial inclinations in the posterior view. This X-ray and this illustration showing how the palmar tilt is reversed in case of the Cooley's fracture, of the fracture of the distal end radius. So now this palmar tilt is reversed to the dorsal side. Again, this fracture of the distal radius, showing illustrations on the plain X-ray, showing how the radial inclinations is reduced below the normal level in a displaced fractured distal radius. This is the ulnar variance, which represent the level of the articular surface of the distal radius and the ulna. So the anatomy of the distal radius, radiological anatomy of the distal radius, include radial inclinations, palmar tilt, and ulnar variance. There is multiple classification for the distal radial fractures, but today's classification or update classification include extra and interarticular fractures, displaced or not displaced fractures. The simple form of the distal radial fracture is extra-articular fractures, which is called Cooley's fractures or bending fractures. Cooley's fractures means fracture of the distal end radius with dorsal, radial, overlapped, and impaction. Dorsal, radial, overlapped, impaction of the distal radial fracture. This is the deformity of the Cooley's fracture, which is called the dinner fork deformity. As regards, there is another variant of the distal radial fracture, which is include compression, and this is most common even high energy fractures. Another pattern of the distal radial fracture includes Smith fractures with volar displacement and overlapped again. So this is the reverse of Cooley's. The other form is Barton fracture, which whether volar lip fracture or dorsal lip fracture, and this is commonly oblique fracture or vertical fracture reaching the articular surface of the radius. But the Cooley's fracture and Smith fracture is still transverse fractures and not reaching the articular surface. Complication of the distal radial fractures include malunion, which is the most common complication of the distal radial fractures, complex regional pain syndrome, extensor pulsus tendon rupture, carpal tunnel syndrome, compression of the median nerve, of course, stiffness, and radial artery injury. As regard the management or treatment of the distal radial fracture, the treatment option include closed reduction and casting, closed reduction binning and casting, closed reduction external fixation with or without binning, open reduction and internal fixations with T-plates, with T-shaped plate. Sometimes we need to do bone graft for certain fractures to compensate for the impaction or collapse at the site of fracture. The treatment goals of the distal radial fractures include to restore inclination to more than 5 degrees, to restore the palmar tilt to neutral, and to restore the length minimal to the neutral, to restore the gap less than the articular gap less than 2 mm, the step off of the articular surface less than 2 mm, and stable distal radioulnar joint. So what are the unstable fracture distal radius which need operative intervention? These fractures, which include fractures that's irreducible, cannot reduce, loss of the reductions early, comminution more than 1/3 of the anteroposterior diameter of the bone, more than 20 degrees of the dorsal tilt, and volar obliquity. Our treatment plan is to do for any stable fracture to be treated in closed reduction, casting, or splinting, and all unstable fracture require intervention as we mentioned before, closed reductions percutaneous wire or external fixator, or open reduction and internal fixation with T-plates with or without bone graft. This is example of the management of certain distal radial fractures. This is example of the T-plate for fracture distal radius, and this is combined T-plate and K-wire fixation. Again, this is the T-plate for the fracture distal radius. And now we are going to discuss another topic, which is the fracture scaphoid. As we know, fracture scaphoid, the scaphoid bone is a boat shaped in the proximal carpal row, and this is the most common carpal bone to be fractured. It articulates with the radius, leonate, capitate, and the trapezium. Mechanically, it represents a mechanical link between the proximal and distal carpal rows, as it controls the wrist stability and carrying compressive loads from the hand across the wrist to the distal forearm. Actually, the scaphoid moves with each movement in the flexion and extension of the wrist. So during the flexion, it flexes with the wrist flexion and extends with the wrist extension, but it also flexes during the radial deviation and extends with the ulnar deviation of the wrist. The mechanism of the scaphoid fractures include hyperextension bending injury. Symptoms and signs of the fracture scaphoid include radial side wrist pain and tenderness on the anatomic snuff box. Radiological assessment of the fracture scaphoid include plain X-ray for the wrist, anteroposterior, lateral, and scaphoid views. The fracture of the scaphoid, the same X-ray should be repeated at 2 to 3 weeks sometimes if the initial firmware is negative, but there is still pain or tenderness at the anatomical snuff box. If the diagnosis still cannot be confirmed with the confidence of the routine films, we need another radiological tool like technetium bone scan or CT scanning or MRI in order of preference. This is example of the bone scan of the scaphoid fractures on the left side. This is MRI showing fracture of the scaphoid waist. Commonly, the second injury would draw the attention to the minimally symptomatic non-united aggravated by the recent event. The last presentation of the fracture or established non-union will demonstrate with resorption at the fracture site with evident space between the two fragments, subchondral sclerosis, and displacement on both posterior and the lateral views of the X-ray. As regard complication of the scaphoid include non-union, malunion, and late sequelae of the carpal instability, post-traumatic arthritis, and of course avascular necrosis of the scaphoid. Whenever there are any findings suggestive of the scaphoid fracture, the patient should be treated for suspected scaphoid fracture. The fracture of the distal bowl of the scaphoid in the grain zone can be managed conservatively with splinting, but the fractures of the proximal bowl is absolute indication for the fixations, while lastly fracture at the waist, if it is unstable, if there is evidence of the displacement, must be fixed. So fracture at the distal bowl at the tubercle segments need splinting. Fracture at the waist, if more than 1 mm displaced, need operoduction and internal fixations, and fracture of the proximal bowl, once you see it, you need to fix it. This is example of the operoduction and internal fixations of the scaphoid fractures with what we call Herbert screws or headless screw. So if this fracture is neglected or missed, there is some sort of the complication that can commonly occur, which is non-union. So this is a simple problem which becomes more difficult when we miss it. So to summarize the most important points in our lectures, to restore the length and the rotation and the axis of the radial bowing in case of the forearm fracture, in the children we need to do after closed reduction above elbow cast either in pronation or supination or neutral according to the level of fractures, or need to do binning of these fractures. In case of the adult, the best method of treatment of the fracture postponed forearm is to do operoduction and internal fixation of the platen screws unless there is skin problems or it's open fractures. Montega fracture dislocation, this is upper third fracture of the ulna with the radial head dislocation. Galeazzi fracture dislocation is distal third shaft of the radius fractures associated with the disruption of the distal radio-ulnar joint. As regard the distal radial fracture, this is a metaphyseal fractures. Cooley's fracture is extra-articular, transverse, dorsal, radial displacement with dinar fork deformity. Complication of the distal radial fracture include malunion, carpal tunnel syndrome, extensor pollicis tendon rupture, and complex regional pain syndrome. Treatment plan or treatment options for distal radial fracture includes closed reduction and casting, closed reduction and bending, operoduction and internal fixations, or external fixation with or without bone graft. Scaphoid, as regards the scaphoid fracture, the scaphoid is the proximal and the bone, boat-shaped bone in the proximal carpal row. Most common carpal bone to be fractured. Hyperextension is a mechanism of injury, and usually there is pain and tenderness at the anatomical snuff box. X-ray may be free. Proximal ball and the displaced fracture is an indication for operoduction and internal fixations. Non-union joint arthritis is a common complications. Thank you.